And many of you have seen this slide already, and I think as an obstetrician, we're really ready to move on and start using our fingers, and we can use the ultrasound in evaluating labour progress more objectively. So why do I propose this? The first thing I want to highlight is that the tools that we have available are very ancient, and most of you are familiar with this, and I'm mindful maybe some of you are sonologists and sonographers. So polygraph is what we use on a daily basis on the labour ward in evaluating the progress of labour, and yet the effectiveness of this tool is inconclusive. Another issue is that our fingers in evaluating the cervical dilatation is for sure very imprecise. My 3 centimetres is definitely different from John's 3 centimetres. So I think it is really time for us to think of alternative ways in assessing labour progress. Timing. Again, I was a bit shocked when I came back to Hong Kong. In my unit, we do digital examination every 2 hourly instead of every 4 hourly, and I asked why. Well, this is how we've been doing it forever. So it's not very evidence-based. And so what we're really pushing ahead is with an objective way for evaluating labour progress. Another issue with regard to vaginal examination. This slide, I will not dwell on all the content, but what I'm telling you is that our fingers have many issues. The way we assess vaginal cervical dilatation is, of course, subjective, imprecise, it's very uncomfortable, and that it doesn't actually have a mean to predict time and mode of delivery. It can provoke preterm labour, and findings cannot be recorded as a major medical legal issue. And for women, they have feelings of shame and they experience a lot of pain. On the right, of course, a lot of reminders as to why we shouldn't unnecessarily examine vaginally, because it can also contribute to infection, and infection can lead to many, many adverse events in the mother and the baby. Intrapartum ultrasound is what we're proposing, and that it is an objective way, it's a reliable way, it's non-invasive, it allows us to document the degree of progress during the second stage of labour, and now I'm proposing for us to even do it for the first stage of labour. It can predict labour outcome in women undergoing induction labour, and what we can see now using ultrasound are listed on the right. How low the head is can be represented by angle progression, and I'll show you the image, and then head to perineal distance. I'll obviously talk you through that as well. We can also use ultrasound to look at how dilated the cervix is. We can certainly tell how the head is it OA, OP, OT, more accurately than using our fingers. We can see how the head goes down the birth canal. We can also evaluate the degree of cathode, not guessing. Is it 3+, is it 2+? Molding, the degree of overlapping, again, can be completely visualized and measured. So how do we do it? Make sure that there's an empty bladder, and you can see that on the image in video on the top. You don't need to buy expensive probe cover. You can simply use a glove. Put a lot of gel on the transducer, place a glove over it, smooth it out, part the labia to minimize soft tissue interference, and then apply adequate pressure to avoid pressure on the clitoris. And then the video in the middle just telling you the direction of pressure, and then the bottom video just shows you we are looking at the fetal head. I'll have a bigger image for that. So what can you see during intrapartum ultrasound? Of course, fetal heart beat, fetal line, presentation, position, station, cervical dilatation, capital molding. And I think we can simply replace some of the vaginal examinations with ultrasound. Here is just a direct comparison between what we feel abdominally and vaginally versus ultrasound. Fetal line, we can use ultrasound to identify the spine position, presentation, exactly direct measure, and then position, ultrasound will allow you to see the eyes, spine, and you can immediately tell whether it's OP, OT, OA, station. We can use angle progression and perineal distance to represent that. Cervical dilatation is direct evaluation, and then capital molding, as I mentioned, we can directly measure, evaluate these. This is the first ultrasound parameter for looking at how low the fetal head is. We place a transducer in the sagittal plane, passing the labia. You can identify the pubic bone, which is the parasagittal portion, and then you can see the fetal head. Angle progression is basically the angle between the two lines represented in this image. It tells you how low the fetal head is. The trouble with this ultrasound parameters is that it may be harder to do at the beginning of labor when the fetal head is too high. So I would recommend using head to perineum distance. And this video tells you how we measure, and you can visualize the parasagittal pubic bone here. Yes, you can see my mouse, and then this is a fetal skull, and you can appreciate the caput here. There's no guessing. You can just measure the depth of this, and once you have the two bony landmarks clearly visualized, you freeze the image, then you bring out the angle ruler on the machine, then you can measure the angle progression. Here shows you that angle progression is highly reproducible, and the differences between observers are about 3%, and within the observer is 1%. And a number to remember is 120 degrees. Let's say I'm on the labor ward. I have to handle this bradycardia, and at the same time, I was told I need to go to theatre. Okay, this woman is fully. I need to run to the theatre, and then I can leave my junior to do this 1-2s once I've done the scan. Angle progression exceeding 120, not OP, so I'm going to run off to handle the emergency in operating theatre, then my junior colleague can then proceed with a 1-2s delivery, because I have the confidence that the chance of a successful vaginal delivery is high, and this is exceeding 120 degrees. We can teach anybody. I've been teaching anybody without prior experience with ultrasound to do this labor scan. The second parameter is head to perineum distance. Transducer, you rotate from sagittal plane to transverse plane, and then tilt the transducer towards the fetal head. Finding the shortest distance between the perineum and the fetal head, that is the head to perineum distance. But the trouble with this is that you do need to press very hard until you cannot press anymore. And I think that can be more subjective, and if the woman is more obese, then that may be adding on to the distance. So I think this parameters is better for before labor onset, and then during labor, then angle progression is better. How do we do it? As I mentioned, you place the transducer transverse and tilt the transducer towards the fetal head, and finding the shortest distance between the perineum and the head and fetal skull. And just now you caught a glimpse of the cervix, and I'll go through that in a minute. Second number you need to remember is 4.5 centimeters. So if the head to perineum distance before onset of labor is less than 4.5 centimeters, then the chance of successful vaginal delivery is higher. And during labor, that number goes down to 3.5. The third parameter is cervical dilatation. Actually, before you go up towards the fetal head, you can already catch a glimpse of the cervix. So sagittal plane to measure the angle progression, rotating the transducer, and then you can see the cervical ring, beautifully demonstrated here in the measure the anterior to the posterior diameter. Let's go through how you find it. Can you just see that there is a caput here? We can use the caput to find the cervical dilatation. You don't necessarily always have to start with the transverse planes. I would then go with the sagittal plane, finding the cervix, the lips anteriorly, and fixing it in the middle of the screen, and then rotate on it, just as I'm demonstrating to you. And trying not to lose the image is important. You rotate on the cervix, and then you fix it when the ring is nicely, clearly visualized. But of course, it's not always so easy, and I'll show you some examples. As I already mentioned, using the caput is helpful. You can find the caput, and you put it in the middle of the screen and rotate on the caput. Then you can find the ring. And of course, you don't measure the caput, you measure the outer perimeter of the caput. That gives you the cervical dilatation. Yes, I think this is nicely demonstrated that you can use the caput to find the cervix. Other considerations, as I mentioned, you need to have an empty bladder, because this is with a bit of bladder. Of course, it allows you to see the cervix nicely. However, if you have a bladder, then that will lift the fetal head. It will not be so accurate for assessing fetal head station, so you need to make sure the bladder is empty. Some examples. This is a very early stage labor, 4 millimeters, and this is a nearly 3 centimeters dilated cervix. And this is again 4 millimeters. This is a 1.6 centimeter dilated cervix. This is slightly bigger dilatation, 4 centimeters to 5.6 centimeters, and you can see the ring beautifully. In our experience, cervical dilatation, less than centimeters, is much easier to visualize on the scan. So I'm not here to say that we should stop doing vaginal examination. We can replace some of our earlier vaginal examinations with ultrasound to minimize all the risks that vaginal examination introduces to the woman. In terms of sonopologram, the concept is not new. It was proposed in 2014, and 12 years later, we are working towards making this change. And this sonopologram integrated all the parameters that we evaluate during a vaginal examination, plus markers on the scan. And the conclusion of this study was that sonopologram was associated with more data successfully being acquired in relation to progress of labor than conventional arteriogram. And I was thinking we need to do this trial. However, COVID hit, and therefore our trial got delayed. In the meanwhile, the Israeli group, who is also very, very supportive of introducing ultrasound in assessing labor progress, published this trial. And this is very important for us because we can use the data to support a bigger study. What they did was that they randomized 90 cases into receiving standard care, vaginal examination, versus ultrasound-guided labor management. And this study proved that ultrasound can reduce intrapartum fever significantly, can reduce clinical chorioamnionitis, can reduce the number of digital examinations, as well as exams per hour. So that gave us hope that perhaps we are really at the beginning of proposing this change. So before we launched our randomized study, we decided to make sure everybody is not so nervous. Because if you talk to any obstetrician, they feel challenged by what we're proposing. They feel like we are trying to take away their job. No, not really. We just want to say that we are at an era whereby ultrasound can be our eyes and ears and perhaps our fingers. We can make labor evaluation progress a lot more objective. So we did this feasibility study in 3 centers, one in Hong Kong, 2 in Spain, to ensure that we did not cause harm. We did this prospectively, and we included women with singleton pregnancy in cephalic presentation for induction labor. And what we did was that we used a paper from our work before to tell them, if you have measured angle progression, it's 95 degrees. That corresponds to a fetal head station of -3. So that I asked them to document clearly on the notes to say that, angle progression, this is the degree, and that's corresponding to fetal head station of -3, -2. Then we were not obviously reducing the quality of care for the women. Based on scan, we started with a transabdominal scan to make sure fetal size was appropriate. Fetal Dopplers were normal AFI, fetal spine, cover position to look at the fetal line. Then we did a transperineal scan to measure the cervical length, angle progression, heterocranial distance, and cervical dilatation. Then during labor, we did a transperineal scan to look at fetal head station, cervical dilatation, and abdominal scan to look at how the fetal head was in replacement of vaginal examination. But if it was not possible to scan, then it's okay to do a vaginal examination. And for those who were not having an epidural, we also asked them to score the level of pain, 0 to 10, and we're grateful for GE for supporting our study. We recruited 100 participants, leading to 20 cases needing cesarean section. 223 intrapartum scans were done, median of 2 beyond the baseline scan. 151 vaginal examinations were performed, median of 1 per participant. There were no adverse fetal or maternal outcomes. Pain score 3 for vaginal examination group and 0 for ultrasound group. Surprisingly, our women were really strong and didn't really report a higher pain score for vaginal examination. We found that cesarean section and epidural anesthesia were associated with a slower rate of change in angle progression, heterocranial distance, and cervical dilatation. On the right, you can see that we plotted angle progression against number of examination, and the red line represents the cesarean section group, and the blue line represents the vaginal delivery group. And clearly, you can see in the vaginal delivery group, the progress was nice and exceeding 120 degrees. Anything less than 120 degrees, the chance of a vaginal delivery would be low. So I got obsessed with the point that whether we really need to evaluate cervical dilatation in assessing labor progress. Must we do that? Can we just rely on fetal head station? Is fetal head station enough? Because all we care about is whether the fetal head is coming down the birth canal. So we've done the study to prove a point, and this is work in progress, manuscript preparation. A bit busy. What we did was we combined all the parameters to see whether we were predictive of cesarean section. And this work was without clinical factors, without acknowledging the maternal factors, maternal size, height, parity, etc. And then we found that head station, as represented by angle progression, was definitely not enough in predicting labor outcome. We definitely needed to add cervical dilatation, if I'm making sense. I was hoping that angle progression was sufficient to predict for cesarean section, but in fact, I needed to add cervical dilatation in predicting this particular labor outcome. Without clinical factors, combine angle progression and cervical dilatation improves prediction of labor outcome. But clinical information is already there, right? Maternal size, parity, method of induction, etc. We add on clinical factors. Now the situation has changed. Angle progression alone is sufficient to predict for cesarean section without cervical dilatation. Clinical information is readily available, and therefore we need to perhaps stop just looking at one thing. We can look at the mother, looking at her parameters to start with, and adding angle progression. And this is predictive of cesarean section, achieving an area under the curve of 0.85, very decent. We're nearly there to implement the new sonoponogram. Steps that we've taken, we've validated the ultrasound parameters of labor progress. We've done a study, we've blinded everybody from ultrasound examination versus vaginal examination. We've demonstrated that some of the vaginal examinations can be replaced by ultrasound. We've provided training to the lay ward healthcare providers, including midwives, and we've ensured reproducibility. We've conducted a feasibility study, and the next step is our randomized trial, due to be started this year, with about 8 centres involved across the globe. And we want to use intrapartum ultrasound to reduce the incidence of intrapartum cachexia, because infection leads to adverse events for the mothers and the babies. We want to reduce the frequency of other complications of childbirth, and we really want to improve women's satisfaction during childbirth. Thank you very much for attending.